Thank you very much to Anzos to invite me to present our trial data. These are my disclosures, unrelated to the current presentation. So I'll start with vitamin D sources. As you know, vitamin D is mostly acquired through sunshine. However, we have certain foods which are fairly rich in vitamin D, and then we can acquire vitamin D through supplementation. However, due to sunscreen and protective clothing and indoor lifestyles, as well as inadequate diet and lack of fortified foods with vitamin D deficiency is prevalent worldwide. With the definition of vitamin D deficiency of 25 OHD below 50 nanomoles per liter, 33% of Australians, despite the sunny climate, are vitamin D deficient, and it is about 1 billion worldwide as well. This is the vitamin D metabolism. Vitamin D is a fat-soluble vitamin, and after ingestion through the diet or synthesis in the skin following sun exposure, it undergoes a series of hydroxylations. And then the active form of vitamin D, 125 OHD, is then binding to VDR receptor, which is a nuclear receptor which binds active vitamin D. The most important thing I want to point out too is that vitamin D has been described in many different tissues, many insulin-sensitive tissues and tissues important for cardiovascular disease such as heart. However, also immune cells. And since this has been found, low vitamin D has been associated with many chronic diseases, including obesity, diabetes, cardiovascular disease, neurological and mental health diseases, cancer, and other conditions, as well as general aging. With regards to cardiometabolic diseases, observational studies have shown that low vitamin D is associated with 33% decreased risk of cardiovascular disease, 50% decreased risk of metabolic syndrome, and about 55% decreased risk of type 2 diabetes. However, as it often happens, observational studies the clinical trials didn't live up to the observational studies. And in fact, this meta-analysis conducted in 2014 by SEDA in JCEM found no effect of vitamin D supplementation on insulin resistance, HbA1c, incident IGT, and type 2 diabetes. However, there was a lot of criticism about these studies, and some of the limitations which have been described were that insufficient doses of vitamin D have been used. There were differences between daily versus monthly dosing. There were relatively small sample sizes in these studies, short durations of interventions. Most of the trials didn't do the supplementation in vitamin D deficient individuals at baseline, and they didn't use gold standard methods for measurement of insulin sensitivity and secretion, and there was no exploration of underlying mechanisms. So the conclusion from these previous studies was that there is very little evidence from well-designed intervention trials, and if there is an effect, it may be only present in vitamin D deficient individuals. So to address these gaps, we conducted a double-blind placebo-controlled trial in overweight and obese adults, and this is the protocol which was published. And we used a regimen of 100,000 units of vitamin D as a bolus, and then 4,000 units daily for a duration of 16 weeks in overweight and obese individuals who were non-diabetic and vitamin D deficient at baseline. And we used glucose clamps, thanks to Steve introducing glucose clamps, and intravenous glucose tolerance tests to measure insulin sensitivity and insulin secretion. And we looked also at markers of inflammation in plasma and PBMCs. So our aims were to establish if vitamin D supplementation provided insufficient dose and duration to overweight and obese but otherwise healthy individuals with vitamin D deficiency will improve insulin sensitivity in vivo and in tissue and or insulin secretion, and to determine if this happens through reduction in chronic low-grade inflammation. So these were the eligibility criteria for the study: 18 to 60 years, vitamin D deficient, overweight and obese with fairly stable body weight and non-diabetic. We had exclusion on morbid obesity because of DEXA. It was well-controlled study where we excluded everybody who was smoking, had higher alcohol use, or suffered of any medical conditions, took any medications or supplements, including contraceptive drugs, and if they were menopausal or were pregnant or lactating, they were also excluded. So this is the study design. After screening medical history, OGTT and bloods and vitamin D status, these individuals were subjected to a series of tests, biopsies, DEXA, IVGTT and CLAN. Then there was the intervention. They were randomized either to placebo or vitamin D, and then this series of tests were repeated. So as you see, we screened heaps of individuals, credit to my PhD students, to end up with 65 individuals, and ultimately 28 and 26 were analyzed. This was because of the rigorous trial methodology and the exclusion criteria which I presented. So we ended up with 54 participants, 65% were males. Age was approximately 32 years of age, BMI 31, and body fat almost 40%. So these are baseline data. There were no demographic differences between the groups at baseline, no differences in sun exposure, dietary vitamin D intake, physical activity, or season of blood collection. And as you can see, we achieved a significant increase of about 60 nanomoles per liter change in vitamin D levels. However, there was no change in anthropometric parameters, including weight, total percent body fat, fat mass, or fat-free mass. None of the glycemic parameters changed. I just note that all of the p-values were adjusted for Bonferroni. This is insulin sensitivity, total area under the curve of insulin, first and second phase insulin secretion. There was no difference in blood pressure between the two groups, systolic, diastolic, pulse pressure, as well as mean arterial pressure, lipid profile, as well as inflammation. We've done a whole panel of inflammatory markers, so this is just a selection of 4. So strength of our study has been that we've tried to address all of the knowledge gaps which existed in the literature at that stage, and we employed rigorous trial protocol, and we have very well characterized cohort. Limitation is obviously small sample size, and we were not powered for secondary outcomes, and the fact that these individuals were well healthy, overweight, and obese limits generalizability. However, we can conclude that vitamin D supplementation had no effect on cardiometabolic risk in these individuals, providing sufficient dose for sufficient duration to vitamin D deficient individuals using gold standard methods, and there was no effect on inflammation. So our data in healthy, overweight, and obese actually matches well with recent meta-analysis in prediabetes and type 2 diabetes. Therefore, we can conclude overall that vitamin D is unlikely to play any role in diabetes prevention or treatment of metabolic disease. So this is my group. I just wanted to point out in particular Ayamosa and Negar Nadepor, who are the 2 PhD students who screened those enormous amount of individuals and done most of the clinical studies. And of course, our funding bodies, both NHMRC as well as our fellowships. Thank you very much.
studies now that have this sort of effect in lots of different areas where the baseline correlates beautifully with your outcome and the supplement does stuff all. What do you think, if you would wildly speculate, is the thing that vitamin D is a marker for that is related to all of these outcomes?
It's a difficult question because you in fact have lot of different diseases. So epidemiological studies, even not only cross-sectional data, but epidemiological studies have very strong data, low vitamin D predicting everything. And in fact, except one recent study in heart failure, all of the studies are negative. All of the randomized control, well done studies are negative. What is it marker of? Could be many things. Could be obesity, inflammation. We found actually, we've done a meta-analysis on looking at inflammation markers in individuals with type 2 diabetes, and we found a modest effect. So it can be a marker of inflammation. There may be potential small benefit. However, at this stage, it doesn't justify any intervention in clinical setting. However, some of our preliminary analysis from the current data seems to show that there might be certain groups which benefit. For example, we see an effect on glucose and percent body fat in Asian population, and it could be obviously a marker of one of the genetic polymorphisms where you might get a benefit. So I think to move forward, I think we need to look in all of these trials which have been done on genetic polymorphisms of vitamin D receptor in particular, but maybe also some of the other steps in the pathways, and to see if there is a specific population which might benefit, and that goes back to the earlier talk of Sam's today on nutrigenomics and the role of personalized medicine.
So did you measure 125 as well?
No, we didn't.
So that's always a question that most of the time 125 is normal. There may be some responders and some people with low 125
Yeah.
impaired enzyme activity. And similarly, when they're non-responders to vitamin D, so they may actually have impaired, active 24, 25, so that the vitamin D is rapidly degraded, and similarly they might have low 125 activity.
Yeah.
So all of those, I think we get a big cohort as well. I think
Yes.
125 would be interesting to measure and look at those individuals that actually did have a low 125 and didn't respond to it.
We didn't have the assay at the time available at Monash Health, and we had to do it real time because as we screened individuals, we had to categorize them. However, even when we did subgroup analysis, and again, this is something what has been confirmed in larger clinical trials, looking at very deficient individuals below 30, there is still no effect on cardiometabolic parameters.
Yeah, I think 125 doesn't really fall until you get, say, below 12.5 level, but really
Yeah.
it's very resistant to change.
Yeah.
Okay, thank you.
Thank you.
Barbara.